Okay, good morning, everyone. I'm Sandra, and Jacinda and I will be presenting on retinitis pigmentosa. We'll start off with the introduction, the pathophysiology, the genetics, mode of inheritance, genotype and phenotype correlation, progression of disease, demographics, signs and symptoms, diagnosis, treatment, and then we will finish off with some recent findings. I will now pass it off to Jacinda for the introduction.
Thank you, Sandra. So what is retinitis pigmentosa? Retinitis pigmentosa is an inherited disorder characterized by abnormalities and degeneration of the photoreceptors. So these are the rods and the cones in the retina, and it causes progressive visual loss. As we all know, genes play a significant role in the pathogenesis of eye diseases. So with retinitis pigmentosa, there are over 40 genes associated with retinitis pigmentosa. And so retinitis pigmentosa occurs due to a variant mutations, which are dependent on the genetic mannerisms, which I will talk about later. So when mutations trigger apoptosis, which triggers in the photoreceptors, which triggers after apoptosis of the surrounding cells. So in this first image here, we have an example of a normal anatomy of the eye, and then we have the anatomy of an eye with retinitis pigmentosa. So with apoptosis, what occurs is the retinal pigment epithelial cells detach and then deposit into the prevascular area. And so this causes, this leaves bony spickle shaped melanin deposits in the retina. And so when we hear retinitis pigmentosa, we think inflammation, but it's more so, there's minimal inflammation occurring and then more so accumulation of the bony spickle shaped melanin in the retina. So there are three modes of inheritance for retinitis pigmentosa. There's autosomal dominant, autosomal recessive, and X-linked. So autosomal dominant retinitis pigmentosa affects about 20 to 25% of patients with retinitis pigmentosa. So if we look at the pedigree here, we see in the first generation, the grandmother has the dominant allele for retinitis pigmentosa, and her husband is unaffected. They have 4 children. We see that 2 of their daughters are unaffected, and a son and daughter inherit the mutated allele. One of the unaffected daughters marries an unaffected man, and they have unaffected children, so they do not pass on the mutated allele. While the daughter with the mutated allele, who is affected, marries an unaffected man. They have 5 children. We see that 2 of their daughters inherit the mutated allele and are affected, as well as one of their sons, and a son and daughter are unaffected. So as I stated before, many genes play a role in the pathogenesis of retinitis pigmentosa, but in autosomal dominant retinitis pigmentosa, the main cause of the gene has been shown to be the RHO gene. So the RHO gene, which is located in chromosome 3, codes for the protein rhodopsin that is shown here in the image. Rhodopsin is found in rod cells in the back of the retina, which is essential for vision and light. So rhodopsin is attached to 11-cis retinol, which is a form of vitamin A. So when light hits the 11-cis retinol, it triggers or activates the rhodopsin, triggering electrical signals. That electrical signal is transmitted to the brain, where it produces or interprets vision. So when there's a missense mutation to the RHO gene, it causes rhodopsin to be altered, and so it prevents that interpretation of light. So the next mode of inheritance is autosomal recessive. Autosomal recessive affects 15 to 20% of patients with retinitis pigmentosa. So if we're looking at this pedigree from bottom up, we see that the paternal grandparents, the grandfather is unaffected while the grandmother has a mutated allele, and so she's a carrier. She passes on that mutated allele to one of her daughters and one of her sons, and one son is unaffected. And then on the paternal side, we see that the grandfather is unaffected while the grandmother has a mutated allele. They have 3 children. They have a daughter with the one mutated allele who's a carrier, and a son and daughter who are unaffected. That son who is a carrier and daughter who's a carrier, they get together. They have 4 children. They have a daughter and son who who inherit two of the mutated alleles and are affected. They have a daughter who's a carrier and a son who's unaffected. And so the main causative gene in autosomal recessive retinitis pigmentosa, we go to the next slide, is the Usher syndrome 2 gene, which is also the main causative gene in Usher syndrome. So Usher syndrome is a genetic disorder that is characterized by sensorineural hearing loss or deafness. So with Usher syndrome, retinal dystrophy is also associated. So in the Usher syndrome 2 gene is a large gene with 73 exons. So when that codes for the protein usherin, which is important in the development and maintenance of the cells of the inner ear and outer ear, as well as the retina. So when there is a frame shift nonsense or missense deletion to or mutation to the Usher syndrome 2 gene, it affects how usherin is encoded. So in this example here, we have a nonsense mutation in the Usher syndrome. So this alters the amino acid encoded by exon 13. So that affects how usherin is how usherin functions, and then it affects or causes loss of function of the retinal cells. Okay. The last mode of inheritance is X-linked retinitis pigmentosa, which affects about 10 to 15% of patients with retinitis pigmentosa. We see in X-linked retinitis pigmentosa a more severe phenotype in the early stages for males, whereas females show no clinically relevant symptoms. So in this category here, we see that the grandmother has the mutated allele with an unaffected husband. They have 4 children. They have a son who's affected, a son who is unaffected, and 2 daughters who are carriers. The affected son had married the unaffected female. They have 2 children. They have a son who's unaffected, and then as we know through X-linked inheritance, the affected father will pass on his mutated allele to the daughter. So we see that here. And then the daughter, one of the daughters who's a carrier, marries an unaffected man. They have 4 children. We see that one son inherits the mutated allele and is affected. A daughter inherits the mutated allele and is a carrier, and a daughter and son are unaffected. And the main causative gene in X-linked retinitis pigmentosa is the RPGR gene, or the retinitis pigmentosa GTPase regulator gene, which is located on chromosome X. So the RPGR gene is called for the protein RPGR protein, or retinitis pigmentosa GTPase protein, which is important for the development of cells in the retina. So when there is a deletion nonsense or missense mutation in the RPGR gene, it causes alternate splicing of the open reading frame 15 in the gene. This causes the RPGR ORF15 mRNA variant. So this affects how it is expressed in the photoreceptors and how it is expressed through the retina cells. Okay, so now that we've talked about the different modes of inheritance, Sandra will now talk about the genotype-phenotype correlations.
So what the genotype-phenotype correlation is, it's a statistical relationship. It predicts a physical trait in a person or abnormality in a patient with a given mutation or group of similar mutations. It has a higher proportion of private mutations. It also has a large phenotypic heterogeneity associated with the same mutation. For autosomal dominant, night blindness can occur. It is very mild though, whereas autosomal recessive, night blindness is more common, and loss of hearing also occurs as well. And then for the progression of the disease, it's a combination of assessments of both visual function and morphology. Visual acuity testing uses ETDRS charts, which are low luminance visual acuity and color vision tests. Retinal morphology is best assessed by OCT and autofluorescence. Genetic testing contributes to the pathophysiological understanding to identify individuals that can benefit from retinal gene therapy. As for the demographics, it's more severe and X-linked, which are men. Female carriers tend to not show any symptoms. There's no specific ethnicity that it affects. However, the mutations in particular genes, which is the Usher USH3 gene that Jacinda was talking about earlier, may be more frequent in Ashkenazi, Jews, and Finns. And genetics of RP is varied. As for the signs and symptoms, Nyctalopia and dark adaptation can occur along with night blindness, mid-peripheral vision loss, far peripheral vision loss, reduced central vision, cataracts, photopsia, flashes of light, and glare. As for the diagnosis, they test the pressure in your eyes and they check how your pupils react to light. So they dilate your pupils with eye drops and so they can see inside your eye. They also use electroretinography for diagnosis. These disorders can affect the retina, which is the layer of the light-sensitive tissue at the back of the eye. Vision loss occurs after light-sensing cells of the retina and gradually deteriorate. Retinal pigment epithelial cells detach and deposit into the perivascular areas, leaving the bony spicule-shaped melanin deposits that Jacinda was talking about earlier, which also helps with the diagnosis. As for treatment, there's no exact treatment. However, wearing UV glasses can protect the retinas. Retinal prosthesis is for severe vision loss, and supplements with antioxidants such as vitamin E, A, and phthalic acid also help with the treatment. Another form of treatment is the implantable eye chip. It acts like a tiny artificial retina. It's made up of 378 electrodes that can convert infrared light from the glasses to the electrical signals that are carried by the optic nerve to the brain. Patients undergo an intensive rehabilitation program that trains their brains to understand and interpret the signals from implants in combination with the remaining natural vision. It's wireless and it has significantly more electrodes, which allows for the transmission of more visual information. As for recent findings, the FDA has cleared an investigational new drug application for the sparing genes therapy, aka SBVN06, for treating RP. It contracts the degeneration of photoreceptors by restoring RDCVF, which is a protein that's secreted by the rods and promotes survival. So as we can see here, the photo's kind of small, but we can see without the treatment, there's no RDCVF in the photoreceptors, whereas with the SBVN06 treatment, there are RDCVF. And then in the study, 33 patients with a mutation in RHO PDE6A or PDE6B gene will receive a subretinal injection of the SBVN06 in their worst seeing eye. They're still evaluating the tolerability of SBVN06, so hopefully some more research. Well, it's in the process, but by 2025, they'll have more updates on the study. Here are sources. Thank you. Any questions?